Welcome to Vet NeuroJar, your audio source for veterinary neurology insights. Today, we're diving deep into a fascinating study about steroid-responsive meningitis-arteritis, also known as SRMA, in dogs. This research, conducted across several veterinary referral hospitals in the UK between 2013 and 2021, sheds light on the magnetic resonance imaging, or MRI, findings associated with this immune-mediated disease. So, let's explore the key aspects of this study and what it means for diagnosing and understanding SRMA in our canine companions. Understanding steroid-responsive meningitis-arteritis. Steroid-responsive meningitis-arteritis is a systemic immune-mediated disease that causes inflammation of the meninges, which are the protective membranes surrounding the spinal cord and the arteries that supply them. Although lesions have been documented in the coronary, mediastinal, and thyroid arteries. The disease is suspected to be immune-mediated because of increased acute phase proteins associated with a systemic immune response and the positive response to treatment with glucocorticoids. SRMA typically affects young dogs, usually between 6 and 18 months old, but it can occur in older dogs as well. It is a common diagnosis in young dogs with fever presented to referral hospitals in the UK. There are two forms of SRMA, acute and chronic. The acute form is characterized by spinal hyperesthesia, cervical rigidity, a stiff gait, and fever. In these cases, a neurological examination is typically unremarkable aside from spinal pain. Cerebrospinal fluid, or CSF, analysis usually shows a non-degenerate neutrophilic pleocytosis. Some dogs may present with severe myelopathic signs and evidence of hemorrhage or diffuse central nervous system inflammation. The chronic form of SRMA is associated with relapses or untreated disease, potentially more significant neurological abnormalities, and variable CSF results. The role of MRI in diagnosing SRMA. Diagnosing SRMA definitively requires histopathological examination. However, most cases are presumptively diagnosed based on the dog's signalment, clinical presentation, CSF analysis, and response to treatment. MRI is not always necessary for diagnosis, but it can be helpful in cases with atypical presentations. Previous studies have shown that MRI abnormalities are common in dogs with SRMA, particularly meningeal, articular facet synovium, and paravertebral muscle contrast enhancement, as well as cervical spinal cord changes.
Objectives and methods. The primary goals of this study were to describe the MRI findings in dogs diagnosed with SRMA in the UK and to determine if there were any significant relationships between these findings and the clinical features or patient outcomes. The researchers hypothesized that dogs with MRI lesions would have a longer disease course, increased mortality, and a higher incidence of relapse. To achieve these objectives, the researchers conducted a multi-center retrospective case series, searching records from 6 UK referral hospitals for dogs diagnosed with SRMA. The inclusion criteria required a presumptive diagnosis of SRMA based on signalment, examination findings, systemic inflammation, pleocytosis on CSF analysis, and response to therapy. The study defined pleocytosis as a CSF total nucleated cell count greater than 5 cells per microliter. Systemic inflammation was defined by increased C-reactive protein concentration, fever, or peripheral neutrophilia. Dogs with a histopathological diagnosis of SRMA were also included, regardless of other results. The researchers collected data on signalment, presenting clinical signs, neurological examination results, clinicopathological results, treatment, and outcomes. Remission was defined as the absence of clinical signs while receiving treatment, and resolution as the absence of signs following treatment discontinuation. Relapse was defined as the recurrence of clinical signs similar to those of the initial presentation, and a positive response to the reinstitution of therapy. MRI procedures and image review. The MRI studies were acquired using 6 different systems, including both high-field and low-field magnets. Contrast was administered using gadolinium-based agents, but patients without contrast administration were not excluded. Image review was performed by a board-certified specialist in diagnostic imaging and a board-certified specialist in veterinary neurology who collaborated and were blinded to all other case details. They assessed the CNS region and surrounding structures for changes in size, signal intensity, contrast enhancement, or evidence of hemorrhage. The location, distribution, and severity of abnormalities were also recorded. Statistical analysis. The researchers compared the presence or absence of MRI findings to binary categorical variables using Fisher's exact tests and to continuous variables using Kruskal-Wallis tests. Stepwise binary logistic regressions were performed for relationships with a p-value less than 0.20 and based on a sample size of at least 40. Statistical significance was set at p less than 0.05.
Key findings of the study. The study included 53 dogs diagnosed with SRMA. The median age at diagnosis was 12 months, with an equal distribution of males and females. The most common breed was crossbreed. The median duration of clinical signs was 5 days. Clinical presentation. Pyrexia was reported in most dogs. Physical examination revealed that most dogs had cervical hyperesthesia, with some having other spinal hyperesthesia. Aside from spinal hyperesthesia, some dogs had other abnormalities noted on neurological assessment. Clinicopathological results. Most dogs had an increased neutrophil count. Serum biochemistry revealed increased aspartate aminotransferase activity and increased creatine kinase activity in some dogs. Serum C-reactive protein concentration was increased in all dogs where measured. CSF analysis showed that most dogs had pleocytosis. Diagnostic imaging findings. The most common MRI abnormality was changes in the paravertebral muscles, followed by meningeal contrast enhancement. Hemorrhage was observed in some cases. Of the dogs presented with paresis or paralysis, most had intramedullary T2, weighted hyperintensity, meningeal enhancement, and intramedullary contrast enhancement. Statistical comparisons for MRI abnormalities. Dogs with spinal cord abnormalities had a significantly higher cisternal CSF total nucleated cell count and a significantly higher likelihood of paresis or paralysis. T2, weighted spinal cord parenchyma hyperintensity, was associated with a significantly higher lumbar CSF total nucleated cell count. Dogs with T2, weighted parenchymal hyperintensity, and those with evidence of hemorrhage were significantly more likely to have paresis or paralysis. Meningeal contrast enhancement was associated with significantly higher peripheral neutrophil counts and cisternal CSF total nucleated cell count. Dogs undergoing high-field MRI studies were significantly more likely to have MRI abnormalities detected and to have meningeal contrast enhancement identified. Treatment and outcomes. Most dogs received glucocorticoids, and some were prescribed additional immunosuppressive agents. The vast majority of dogs survived to discharge. Follow-up data revealed that all dogs achieved clinical remission, and some achieved clinical resolution. Relapse was recorded in some dogs.
Discussion and clinical significance. This study provides valuable insights into the MRI findings associated with SRMA in dogs in the UK. The researchers found that abnormalities were identified in most MRI studies, with paravertebral muscle changes being the most prevalent. The presence of MRI spinal cord abnormalities was associated with higher cisternal CSF total nucleated cell count and a higher incidence of paresis or paralysis. Hemorrhage and T2, weighted spinal cord hyperintensity, were significantly related to paresis or paralysis. Comparison to previous studies. The researchers compared their findings to previous SRMA case series and found similarities in the total number of abnormal MRI studies and the number of cases with spinal cord parenchymal T2, weighted hyperintensity, and spinal cord parenchymal contrast enhancement. However, the prevalence of meningeal contrast enhancement was lower in this study compared to others. Study limitations. The study had several limitations, including its retrospective nature, the use of both low-field and high-field MRI systems, and the potential for selection bias in which dogs underwent MRI. The researchers also noted that the study population may not be fully representative of the global SRMA population. Clinical recommendations. Despite these limitations, the study provides valuable information for veterinarians diagnosing and managing SRMA in dogs. The authors recommend considering MRI for dogs with atypical SRMA presentations, myelopathic signs, or poor response to appropriate therapy. The study highlights that SRMA lesions can be severe and extensive and not necessarily involving the cervical region. Recognizing the MRI findings associated with SRMA can aid in diagnosis and improve patient outcomes. That wraps up our discussion on MRI findings in dogs with steroid-responsive meningitis-arteritis. We hope this episode has provided you with valuable insights into this important topic in veterinary neurology. Thank you for listening to Vet Neuro Jar. Keep those minds inspired, hearts light, and tails wagging.